Good afternoon. Let me ask you a question. What would you prefer? This type of car or that type of car? I think it's quite obvious. I thank you for your attention. We all like to embrace innovation. It's all about innovation around us. We as surgeons might even be redundant in the future as innovation is going on, and we might even attempt to operate virtually on augmented reality patients. And also in implants, there are innovations. But let me ask you 3 questions. First of all, are all innovations improvements? Do we, as surgeons, embrace innovations for ourselves or for our patients? And what about the risk-benefit analysis? But most importantly, and that's really the fundamental questions, is what if I was a patient? What would you do then? If I was a patient, I would have 3 top priorities. I would like to have good function, I would like to have minimal risks, and I would like to have a long-lasting result. Both 2 may depend more on the surgeon, the last one may be somewhat more on the implant. And after these 3 priorities, only after these 3 priorities, I would have other secondary priorities. I would look at fast rehabilitation, a small scar. I would certainly look at costs and easy revision. But that's only a secondary priority. Let's look first at the first one, good function. You want to restore biomechanics, you want to preserve soft tissue, and you want a large range of implant sizes that allows you to restore the biomechanics optimally. This is a question of preoperative planning and proper component positioning. This is a question of surgical technique and trying to preserve the muscle function. Both are more depending on training than on innovation. The third one is more depending on money than on innovation. What you really want is a huge amount of implants that cover the whole range of anatomical variation, and for that, you want a company to have the largest possible sizes of implants. And the companies want to have the smallest stock possible, and so there is a conflict between that. Restoring biomechanics is about planning, and it's about experience and dedication of the team, but it can also be innovative. What would you prefer as a patient? Well, if you have to believe this evidence from the literature, and this is a randomized controlled trial looking at the evidence for computer-assisted cup positioning, and this was the conclusions of the authors. Our observations suggest that computer-assisted surgery used to cup placement does not confer any substantial advantage in terms of function, wear rate, survivorship at 10 years. The added cost and surgical time was, for the moment, not shown to be beneficial. Good function depends on implants choices, and you have the pragmatic, expensive solution having all different sizes of implants, or you have a more innovative solution. Now let's look at what literature says about that. Modular stems versus non-modular stems. Well, we found that the use of modular necks did not improve scores, reduce likelihood of complications of reoperations. And because the added risk, higher reported risk, we don't really want to use it systematically, except if you have, in extremely rare cases, anatomy that cannot be restored with a normal stem. But it has also a price. And you see here that at 10 to 15 years, there is 30% more revisions when you use an exchangeable neck. So yes, innovation can be a solution for some problems, but can also generate new problems. Now, the second priority for me was minimize risks. And you have surgical risk, you have preoperative, postoperative complications, and you have periprosthetic fractures. Now, surgical risk, they depend on your anesthesiologist, the malpositioning of the implant, perioperative fractures, complications might be dislocation, infection, and late fractures. All these are depending more on the surgeon than on innovations. So teaching here is more important to me than innovation. What about periprosthetic fractures? But maybe there is a place for innovation. The risk of dislocation, that's certainly a concern. There have been innovative solutions. The standard cups, it depends mainly on the training and the experience of the surgeon, but there have been innovative solutions to try to reduce that. What would you prefer as a patient? Well, literature is quite clear. Dual mobility might have higher wear and intraprosthetic dislocation. I think it's a very good innovation, but maybe it should be reserved to patients which are at high risk because of the drawbacks. Metal on metal, we have been there, we have been back from there. They are largely abandoned. Ceramic on metal have also been largely abandoned. And then the very big heads and thin ceramics are squeaking a lot, and they are never been really adopted in large numbers. So all these innovations to try to reduce dislocation risks have not been embraced in large scales. What about periprosthetic fractures? Well, they are much more important, about twice as frequent when you use an uncemented stem compared to a cemented stem. Some designs have a higher fracture rate as others. And I think we might solve that with improved designs of implant. We might. We didn't show it for the moment, but we might. I think there is some room for improvement. What about long-lasting? Because I want, as a third priority, to have an implant that lasts very long. Well, fixation is depending on the implant shape, on the coating, on the cementing technique. Wear and osteolysis is a material issue in most cases, and sometimes an implant position issue. Here, innovation might be an advantage. But it's very, very difficult to show that a new implant will do better than the implants that we have today, because the implants we have today already have a very, very good survivorship at 10, 20, or even 30 years. This is an interesting slide. Look at all these different innovations that have been published here, and it's too small to read them, but there are many, many. It's all randomized trials. And on the left side of the picture, on the right side for you on the picture, you have worse than standard. And standard is all cemented poly, all cemented stem, 28 millimeter metal head, and standard polyethylene. Look where we are with all these innovations. All worse or comparable to the golden standard. The conclusion of these authors was clear. New implant combinations were not found to be better than the reference implant combination, which was really an old-fashioned way of thinking. Metal on polyethylene, not even highly cross-linked polyethylene, small heads cemented on the stem side and on the acetabular side, in terms of risk of revision and in terms of function. I think there is one innovation that really made it. And I think if something has changed the game in the last 15, 20 years, it's cross-linked polyethylene. And this has been shown to have better results in large series. And that's probably one of the only ones in the last 20 years that really have demonstrated a real benefit in terms of survival. Stress shielding is certainly an issue. And here maybe new designs can be favorable. You see here conventional stems with some stress shielding depending on the design, and some newer stems, smaller stems, might improve that. But there is also a drawback. Some of the new designs will not perform that well as the older ones, and all short stems are not equal. Some short stems will also fail due to loosening. We're not always aware of which one will be performing best on the very long run. As a conclusion, what do we want as a patient? Well, we want this. We want a forgotten hip that lasts for a lifetime. That's what I want if I want a hip. What have we learned from the past? I think innovation should only be used to treat or to address real existing problems. I think innovation requires extensive testing. extensive testing and long-term follow-up. And I think, and that's the most important message of today, innovation does not replace training. Thank you.